In residency, it's your one time to see every single procedure in neurosurgery, whether it's peripheral nerve, skull base, vascular, spine, something crazy. And the more time you go home, the less time you get to soak it up. So I love that. Soak it up. And today I want to introduce you to one of our 3 graduating chief residents. Dr. Stephen Miranda is a very unique individual because unlike many neurosurgeons or many doctors, he's not just focused on the science of molecular biology or the technology or the engineering aspects. He has a unique interest in decision making and some of the challenges of patient-centered care. In this interview, we tackle subjects such as COVID, suicide, moral injury, burnout, as well as some of the positive things that happen in neurosurgery, such as his contributions as a chief resident to shaping the direction of our department, because there was leadership change during his time. So I think it's a fascinating interview, and please listen to Dr. Stephen Miranda. Good morning, this is Dr. Lee here with Dr. Stephen Miranda, our graduating chief, and it's May 2024, so our chiefs are now getting ready to graduate. And I thought I'd introduce you to one of our stars who graduated from Stanford University and then attended medical school at the University of Rochester. And then he spent additional time with Dr. Atul Gawande, the famous Dr. Atul Gawande at the Brigham, learning about decision-making in surgery. And it's an interesting topic because how do we make decisions? How do we make the right decisions? So I'd love to explore with him what his thoughts are after now learning how to become a neurosurgeon. And he also faced a lot of challenges during his residency, the biggest one being COVID, and then the second one being a new chairman. And the new chairman brings new ideas and new directions. So let me turn it over to Dr. Miranda.
Thank you, Dr. Lee. Well, it's great to be here with one of my favorite mentors in this program, one of the most experienced surgeons we have in this very historic building. Obviously remember coming here many years ago, my internship, during my interview here, just soaking in the history, the first surgeries performed in North America in this very building. And yeah, like Dr. Lee mentioned, this entire process of healthcare and surgery and growth is one that continues throughout your career. I mean, Dr. Lee shared so much about how much he continues to learn, and for me, it's really been a fantastic journey here. Going over to California, coming back, and seeing different thinkers and ideas like you talked about. Yeah, it's been an incredible experience. I mean, I'm happy to tell you more about Chief Rear, but it's really the culmination of just so many patients and stories we become enmeshed in, all the people we take care of, and yeah, the challenges you overcome. I mean, you can't predict the future, but things like COVID happen, these crises, and it's incredible to be part of such a great team.
That's great. You mentioned something interesting, which is patient stories. And I've become very interested in our patient stories. And not to put you on the spot, but any particular stories that might inform your decision-making for the future.
Yeah, I mean, there are so many that come to mind. I mean, patient stories, it's something we've talked about so much during our time together, but is a big reason of why I got into medicine. I recognize that we focus a lot as scientists on the pathology, the diseases in the body that we can treat and fix, and what we think we have clear answers for. But a lot of it is shaped by uncertainty, and then each individual has a very different experience. And a lot of the care we deliver is really tending to that rather than the surgical disease, especially because we don't have a lot of clear answers for many of the problems we face, not just in neurosurgery, but in everything. And so understanding how we navigate that has been a big passion of mine, bringing that into neurosurgery. But yeah, there have been a lot of situations where we, often as the front line, the chief residents, we talk to families and patients in the worst time of their lives, and they have to make very difficult decisions about, do we continue, let's say, care in the ICU? Do we keep our loved one on life support? And none of us have the ability or a crystal ball to predict what their next few months or weeks will be like. And there's often these moments where there's no going back, or people worry about, their left family members ending up in states they may not have wanted. And so we deal in the very high stakes situations. And so some of my research and other team members of mine have tried to dig into that and understand how we make these decisions, but it's very complex. I'll just leave it at that.
Yeah. I remember in particular, Dr. Miranda had conducted an interesting study where he was listening in on our brain tumor conference as a researcher. And I thought that was really unique, a very interesting idea, because patients hear different things than the practitioners. And I'm just curious, what was the conclusion of that research?
Well, yeah, I mean, we're still working through, it's a huge amount of data. Obviously, because we spent a lot of time with the patients themselves, we did, observe some of the brain tumor discussions, but the fascinating part was the spending time and interviewing these patients, talking to them and understanding how they go through what is a really unique existential experience that I think even as physicians, even though we take care of this so much, we have a hard time wrapping our heads around folks who may have a terminal diagnosis, who are trying to grapple with that at the same time while they're pursuing treatment. And I think that's something that we're just tapping into from an anthropologic sense in a lot of the literature. But I think one of the big things that we're learning is that, people have an intense desire to meet their goals, and we can help them do that. But it's important that we, really understand where their head's at when we're providing them with information about treatments that we're also still learning about. So it's a very complex interplay, and I'll tell you more once we sort through it.
I often feel like, at least specifically in the field of glioblastoma or brain tumor, the most malignant brain tumor we deal with, there is a discrepancy between how many practitioners feel versus what we tell our patients or what the brain tumor board might recommend. And obviously there's no right answer once the tumor recurs, and so consequently, it's very difficult to guide patients. So I look forward to that work in your publication.
Absolutely.
So I didn't realize that it's not yet published. So.
Yeah, no, I mean, it's hard to know what the conclusion will be until we finish our work. But I think that's one thing that's really come out of this is that, like you said, it's a lot of it's uncertainty around what the right treatments are. It's so different based on the patient and their genetics and their molecular information that we're all learning about that on the science side, that we're seeing from the patients that one of the things they really value is the relationship they have with their doctor, how much they trust them, and allowing the physician oncologist to guide them through this process. That is a big component of healthcare, and it's one of the reasons I've been interested in focusing on how we can cultivate that skill, develop those skills as well, because it's not just the science on its own. It's helping understand what's important to the patient, and that's what we've been learning through this.
That makes a lot of sense, because sometimes I see some of the procedures that we do or interventions that we take, and you wonder why we're being so aggressive, but you come to appreciate, and at least just what I heard you say, is that the individuals, the families, they come to place so much faith on the practitioner, and that's very human. That's the human part of medicine that you cannot just eliminate with science, because if you just follow the science, then it doesn't know where to take us. So interesting.
Yeah, and it's a joint thing. People want to continue living full lives, and I think that's a big thing that we want to support as well. So anyway, very complex issues that we'll continue to learn about through our careers.
The COVID experience, I think, has resulted in Penn residents deciding that they want to form a union. And there's a lot that goes into that, but I think as a resident, probably in the peak of your clinical years when COVID hit, you experienced the brunt of the challenges of taking care of patients during COVID when we had limited access to physical protective equipment, PPE. We didn't have masks. We didn't know what the right protocols were. And so your experience, you were deep in the front line, and just wanted to get your, for historical purposes, what was your experience?
Yeah, I mean, it was really a unique time in medicine. I think there are a few times in our history in this country where the entire focus is on the medical front line. I felt really privileged to be part of it, just given how I think so many frontline workers responded. My wife was an ICU nurse at the time. I think they were the real heroes in a lot of this. The number of COVID patients she cared for, putting herself at risk. It's far more, I think, than what a lot of the doctors were doing. And I think it was amazing that our culture and society really recognized that, and especially in places like New York, where the nurses would be cheered on the way in. It was a really cool time to see our profession and all of our allied professions in that spotlight for the work that honestly people do every day, thanklessly. So that was really, really cool. I think one of the interesting challenges was how it intersected with the broader politics and society, and how we, thought about, to bend the curve and flatten the curve. And I think it exposed a lot of how much we have to learn about public health response and to bolster that in our country. And so I think it was a really interesting time to see how our system could handle such a massive stress. And I think, I think a lot of people, really performed so admirably during that time. I think though exposed, I think a lot of the mental health and burnout that a lot of, practitioners face. I think, among physicians, the suicide rate is higher than the general population. I had a very close friend from medical school commit suicide during COVID, related to the stress and the mental health burden she was already facing, and it's extremely challenging, I think. So, it was a unique time to go through. I think, fortunately, here at Penn, we did a really fantastic job, I think, with our health systems, our testing, our screening. They provided us with great PPE. I think I was really fortunate to be able to continue my surgical training during that time. I remember being in emergent situations, wearing the masks, and in the trauma hospital doing surgeries when we didn't know if patients' COVID status or were, at risk. And I think it's crazy to think about that, how we've all gotten through that as a society and learned so much. So it's been, it was a huge marker of our training, but I'm sure there'll be other things in the many years to come.
Well, it's interesting because I think back to what are some of the events that happened during my residency, and during my residency was 9/11. I remember being in the operating room doing a elective spine surgery, and a nurse running into the operating room saying a plane hit the World Trade Center, and we thought she was crazy. And then everything shutting down because Schwenksville, Pennsylvania was very close to where I did my training in Pittsburgh. So that was a defining event during my time, although it didn't have the same lasting repercussions that COVID did. Obviously, we're very fortunate because we had in our department the Nobel Prize winner for the COVID vaccine. So in many respects, we had access to the epicenter of the cure for the disease, or at least the prevention through vaccination. I guess just to think about physician burnout and physician. I think that you and I have spoken about moral injury and how physicians have learned to co-opt that phrase from the Vietnam War experience of soldiers, and moral injury amongst physicians, and how when we witness events or situations that challenge our moral fiber, we can be morally injured, and then it's more difficult to proceed. And
yeah, wow, what a challenging concept, to dive into. But it's part of, I think it is a part of training in all the healthcare fields. We've talked a lot about this, but for kind of a general audience, sometimes a lot of this literature I think came out of nursing literature, moral distress. A lot of times nurses or folks lower in the hierarchy have to carry out decisions made by others, and that leads to a lot of burnout in those dimensions. So a lot of the literature on this comes from nurses or other folks who feel like they have to carry out orders that they may not feel could be right for patients, or that they, it's a very complex topic, but sometimes folks on the ground may not have the full picture that the folks in charge are. And during COVID, there was a lot of uncertainty about how we made a lot of decisions about, who should be awarded certain PPE, how should we spread our workforce when those resources are limited. So I think that was a prime example of where we had to make a lot of difficult choices at a large scale in a rapid amount of time. So, I think that's, one component. I think the more common thing that we might experience as surgeons, though, ourselves is, I think there's a lot of interesting literature or writing about this, is like second victim syndrome. Just by the nature of what we do, just like firefighters or police officers, you're often in difficult emergency situations where the outcome may be out of your hands, or even despite your best efforts, patients may die or have complications. And they sort of live on with you because you were taking care of them. And I think that's something that accumulates over, your training, over your career. And as you, grow up a bit, then you are more responsible for those outcomes. There's nobody above you to call for help. And so I think that's something that we all grow and learn to cope with as we take on this responsibility. So I think it's been, helpful to have, mentors to talk to about some of this stuff. And there's no shortage of that here.
Yeah, well, that's great. The second injury that we experience, and clearly, I think you have a very good point. Nurses feel it much more acutely because they are really much more on the front line in that regard. Well, let's transition to another topic, which is leadership change. And you got a chance to experience roughly half of your residency with our former chair, and now a lot of change with our new chair. And just get your thoughts.
Yeah, sure. I mean, this is maybe a little bit in the world of neurosurgery, but yeah, I mean, for those in our field, we've been very fortunate to have two titans in our world, lead this department, Dr. Grady, and then now Dr. Yosher. So it's, I've felt very fortunate, honestly, to have two big mentors as I, have sought opportunities in my career, and not to mention sort of the superstars we have, Dr. Lee and others in each subspecialty. So it's been a very, cool experience to witness that. And, part of, any organization that grows, evolves, changes is, you get to help shape that, to come in, towards, let's say, the tail end of one era and then be at the start of the new one. I felt like our voices were really a part of shaping, how we do things as an organization, how we can improve the training for those behind us. And I hope that'll be part of our legacy here as chief residents. The surgical training, the educational conferences, the anatomy labs, whatever, comes here afterwards. It'll be nice to have maybe a footprint live on in the junior residents we train and the students who we kind of have watched join the program. So, I mean, it goes by fast.
Yeah, no, it's been really fun to have you here. And there's another big accomplishment of yours was to find your wife.
No, absolutely. I mean, these are such tumultuous times in our lives and careers that it's hard to, maybe one day I'll write a book about it. But I was very fortunate to meet my wife here in Philadelphia, and she's been a huge support. Couldn't have done this without her.
So you're going to start a new job. You're not going to be far. You'll be at Mount Sinai with great colleagues there who I'm familiar with. And so what's your lay public book going to be? Your checklist manifesto? Or what's your ambition?
Yeah, I mean, that has always been a dream to formalize some of the writings I've been doing and talking about with Dr. Lee for so long. But yeah, I think it'll come out a lot of what we've just talked about. You know, the intersection of all of these ethical concepts and tough decisions we make and stories from the front lines. I think for me, writing this is just part of learning about what you've been through, and an experience like neurosurgery, and in your training, you are witness to so many incredible things that it just sometimes takes some processing to figure it out. But yeah, I couldn't have dreamed of a better experience, and how much I've learned through this time. So.
Yeah. All right. Well, you're not going to give away your book idea now. I can understand that. But how about any last messages to the junior residents, your trainees, your mentees?
Yeah, I mean, they've heard this from me so many times, but I think just soak it up. I mean, this is, every moment you have is a moment to learn. I think that's something that kind of gets lost in the number of hours that we work in the hospital. It can really add up. It can become exhausting. But each patient is something different. And if you don't have your eyes open, you won't recognize that you can, even if you've done something 1,000 times, that 1,001st time you might learn something different or see something new. And there's just like in any other schooling, there's only so many times where you have the ability to focus on, this is my time to develop and learn and grow. So I've really appreciated that coming to the end of this chapter, that every case of Dr. Lee, there's always something I could do more efficiently. So
yeah, I think that's great advice. In residency, it's your one time to see every single procedure in neurosurgery, whether it's peripheral nerve, skull base, vascular, spine, something crazy. And the more time you go home, the less time you get to soak it up. So I love that. Soak it up. All right, well, very good.
take
Bye-bye.
care.